Hi guys, it's Dr. Zach Wurth. Unfortunately, Dr. Bryn isn't able to join us today, but we are with our special guest, Dr. TJ Williamson of Longmont Joint and Spine, and I'm going to kick it over to him to introduce himself to you guys.
Yeah, so I'm TJ Williamson. I'm a graduate from Logan University in St. Louis. I graduated last December and then moved out to Colorado this past January and started practicing as a chiropractor in Longmont Joint and Spine, kind of on the southern end of Longmont. And then, coronavirus hit, so took a little spell there where I didn't practice much, but I'm back and kind of back in the swing of things now. So.
Yeah, that's awesome. I know Bryn and I, we first met you. You graduated after us, and you got to start practicing before us. So I know we were pretty jealous of you on that end. But no, it's good. We're glad that you're back to being able to practice and all that. And we're obviously excited to get going here. Hopefully, in the next month or so, we'll have the doors open and all that. Today, we are here to talk to you guys today about some common myths with low back pain. As you guys know, low back pain, as we've talked about here, is a really common disability worldwide. And kind of one of the biggest perpetuators in that is kind of our own thoughts and the stigmatisms around low back pain. So we're going to kind of break down some of the top 10 myths, I guess you could say, and we're going to kind of give you some facts to combat that as well. So let's kind of get into it. So the first myth we're going to talk about is this. Low back pain is usually a serious medical condition. And I'll toss it over to you, TJ, to talk about that one.
Yeah, so, a lot of times, like when someone has an acute onset of low back pain, sometimes it can just come out of nowhere without any sort of injury or any cause that we know about. And so it can be a really scary thing. And so that's a large part of, treatment and educating a patient is letting them know that, no, like your back pain's okay. It's probably not, due to something that's scary or life-threatening. And so it's really important to know that on average, while there are scary things that can cause low back pain, like tumors or fractures or infections, whatever the case may be, those only really make up 1% to 2% of all causes of back pain. So if you woke up tomorrow with a little bit of back pain, I mean, you're already looking at greater than a 90% chance that the cause of your pain is likely, something that's safe and probably going to get better over time.
Yeah, exactly. And that's our jobs as physicians. That's what we do. We rule out those things. That's what we do in our examination and all and those sort of things. And like you said, it's incredibly rare, and I think that is one that usually people do think when you get that acute onset. Oh my gosh, like how serious is this? Like what's going to happen next, and all that sort of things. So that kind of leads us into number 2, and that being low back pain will become persistent and deteriorate later in life. We know this kind of isn't to be true. Most episodes of low back pain do improve over time. There's little to no evidence to support that low back pain continues on with your age, or that it's something that you're going to carry around with you the rest of your life or anything like that. I don't know if you have anything to say, TJ, on that.
Yeah, actually, we've done research on like what is the peak incidence or what is the age group of people who have low back pain more than anyone else, and it's actually in your 40s to 50s.
Okay.
So, if we really did think that low back pain was caused by us deteriorating or degenerating, as some will say, we would see a steady increase as age goes on. But there's actually a little bit of a drop off once you start hitting your 60s, 70s. There's actually less prevalence, or there's less likelihood of having low back pain than in your 40s and 50s. So
nice.
That means we need to look somewhere else for a cause.
Yeah, absolutely. 100%. And this, again, kind of, some of these myths kind of coincide with one another, but we'll list them anyways. The next being persistent low back pain is always due to damage, to tissue damage specifically. I think that a common misconception is, again, with that acute onset, whether it's chronic, whatever it may be, is that when you have pain, whether it be in your spine, whether it be in your elbow, it doesn't matter where, is that damage is being done, that there's something in there that's just eating away at tissue, and you have this terrible mindset about it, and it's that's what you think is the cause of your pain. When we know that pain doesn't always equal tissue damage, oftentimes we can experience an injury, and that muscle or the soft tissue around it heals, but oftentimes the neurology doesn't forget, and when we can kind of go through certain motions and movement, it almost kind of in a sense wakes that up again. So yeah, I don't know if you have any comment to that, but
Sure. Yeah. Like, and that's one thing that I have a really strong passion for is just researching pain and, how to
Sure.
understand pain. And
Yep.
we can use really far out examples like phantom limb pain is an example where, people can feel pain in a limb that was once amputated. So
Sure.
how do we explain that if, if there's not even a hand to even feel pain from? So can we really say
Exactly.
that I suddenly damaged a hand that doesn't exist? So we've learned a lot more that it's more about a lot of cognitive and emotional and a combination of things that cause pain, not just tissue damage. Now, yeah, like you said, we could get a low back strain or sprain or, pull a muscle here or there, or whatever the case may be. But a lot of times there is no evidence for this when we're assessing patients with low back pain. And
Yeah.
something as simple as being in a distressed state, being stressed out emotionally or physically, these can increase our pain sensitivities. So, if I'm having a bad day, it's raining outside, I just heard really bad news that I just got off the phone, and, my girlfriend's dumping me, and, life's really bad, and I stub my
Yeah.
toe. Stubbing my toe is going to be the worst feeling in the world. But if I compare that to, scenario B, where I've just won the lottery, I'm jumping up and down, I'm really in this happy mood, and I stub my toe, I'm probably not even going to notice it.
Yeah. Exactly.
So
That's
it's a
an
good
excellent
testament
point.
to like mindsets and our emotional state and our physical health and psychological health go hand in hand, and that we need to assess pain from a multidimensional perspective.
Absolutely. I know that's something that Dr. Brennan and I talked about on our last on our last Wurth Wednesday video. Wow, I'm jumping to podcasts now. Is that, yeah, it very much is multifactorial. It's not, you can't approach this at one thing is causing the harm or it's causing damage. It's, there are many different approaches to this. And that's what we like to do in our office is kind of find the root cause of what's going on. So looking at the whole picture and everything like that to kind of see what's affecting you. Jumping to number 4, this one's interesting. So scans, x-rays, MRI, CT scan, all those sort of things, all those sort of pictures that you can get of different anatomy let me start. So scans are always needed to detect the cause of low back pain. This is something that is definitely been on the forefront in chiropractic here the last few years or however long, is x-rays and how often we should x-ray our patients, how necessary is it? And then, kind of what that means to the patient in terms of seeing and being told they have cervical or spine degeneration or pelvic unleveling, and some of those different kind of key terms can really affect how a patient thinks about their low back pain.
Yeah, absolutely. Yeah, like chiropractors were classically known in their earlier stages of development for, x-raying all their patients and looking for misalignments and saying that the misalignments were the cause of the pain. But we've found that there is no correlation between, spinal misalignments and pain. And to add to that, nobody has perfectly straight spine. Everyone's got some asymmetry to it. So why does this person with an asymmetrical spine have pain, but this person with an asymmetrical spine does not have pain? So we also need to think about the negative effects of taking imaging too liberally. Is that it causes worry, and what have we learned about worry and stress and psychological concerns? That these will amplify pain that we have, whether we know where it's coming from or not. If we're focused and dwelling on our images, then that can actually be a negative in the long run. So
yeah. Absolutely, definitely. This one kind of gets a little bit more into the pain. The next myth, this myth is pain related to exercise and movement is always warning that harm is being done to the spine and a signal to stop an activity. So like we said before, some of these start to coincide. This is a little bit kind of related to one earlier, being related to tissue damage with movement. And this notion I feel like people have that once they get back pain, and with any sort of pain, is that they need to rest and they need to stop moving. And if they do move and there's pain, that it's that harm, that something bad's happening, that they should stop. When in fact, the spine is, this amazing structure that's meant to move in all these sort of different directions and under certain loads. And it's incredibly healthy, in fact, for those joints and muscles. So, yeah.
Yeah, absolutely. So, pain with movement is just an indication of your sensitivity to movement. It's not necessarily an indication of damage. And so I like to explain this to patients sort of as if I were to try to go for a 300-pound bench press. If I did it, if I tried to do 300 pounds tomorrow, it'd be way too much. I would probably actually injure myself and be
Mm-hmm.
bad news. But, if I started off with a gradual overload over a period of weeks or months, I might have a little bit of soreness throughout that time. But as I'm, sticking to my schedule, and I'm staying active and I'm challenging my muscles, I'm developing a stronger threshold. And in this case, we're talking about just absolute brute strength of movement, but the same can be applied for pain sensitivity. The more we expose ourselves to little bits of pain that are tolerable, they're not 10 out of 10 pain, but maybe a 4 or 5 out of 10 pain. The more we do this, and the more we realize this isn't, bad for the body, it's not damaging in any way, the more we'll actually develop desensitization to pain. So movement will feel a little bit better.
Yeah, absolutely. And I like how you've had a few examples. I think that's really important in patient care, is using examples that patients can relate to. Kind of puts them on the same level, and it gives them a better understanding, I guess, about what's going on. Moving on to number 6. So low back pain is caused by poor posture while sitting, standing, and lifting. Well, I mean, if you can see me right here as I have to kind of bend in to read, I mean, my posture is what most would consider probably incredibly poor. There's been plenty of research on this, and Dr. Brennan and I have talked about this a little bit in terms of what is a perfect posture. Does it exist? And we know that it doesn't really exist, and that, posture's correlation or association to pain is not very strong, and that if you see someone walking down the street or you notice poor posture, the odds they have pain is probably just as high as the person who's walking down the street with perfect posture. So it's not a great indication of pain or other things like that. So I don't know if you have anything to mention about that.
Yeah, I love this one. This is one of the most common things that, when I'm meeting a patient, they say,
Yep.
I have low back pain or I have neck pain. I know it's because of my posture.
Yeah, absolutely.
And we've hammered this into their heads through just general like social media and just general social acceptance of this fact that's not actually a fact, that posture causes pain. And we look at like things like text neck is always something we talk about, or making ergonomic changes to our desks at work. Well, what has research shown us when we actually look at the people who did make changes to their ergonomic setting at work, is that it doesn't really change the rates of back pain. It doesn't change rates of neck pain. It doesn't make anything better. But what actually does link to back and neck pain in a work-related environment is job satisfaction. So again, it links back to the tie between pain sensitivity and emotional health and cognitive beliefs. We have not found any link between poor posture and pain, and it's more so about how frequently are you changing your posture, or how often are you moving versus staying static. Like, even in what we think is perfect position, if we're there statically for a long time, it's going to start to ache a little bit.
Yeah, 100%. And I'm, again, glad you brought in the kind of biopsychosocial model to it. Like, there's tons of factors that play into any sort of condition. The next myth is kind of another incredibly common one that I certainly hear, and I'm sure you do too, is that low back pain is caused by weak core muscles, and having a strong core will protect you against low back pain. I think even the misconception of what kind of our core is and what its function is supposed to do can be commonly misconstrued, and kind of ways that we can achieve that. Ways that we like to do it in our office when it eventually opens is just simple belly breathing and simple things like that to kind of help reinforce that lumbar spine. But yet the core muscles, I think everyone thinks if they have a 6-pack or something that they're gonna all of a sudden never have back pain or anything like that. I don't know.
And it's such a mainstay in chiropractic and physical therapy, and anyone who's dealing with back pain on a daily basis, that people who have these beliefs, including physicians who've not been informed appropriately, or maybe they were just educated long ago, that the go-to is always, well, we need to strengthen your core. Let's do more core exercises. We need to teach you how to lift with a stiff core. But what have we learned when we've actually just observed people with low back pain is they move with a more stiff and rigid core than those who don't. So if the people who are not in pain move a little bit more fluidly, a little bit more loosely, why is it that they don't have pain? So it actually needs to be looked at from a different perspective. If you're tense all the time, you move real stiff, you're afraid to bend at the low back, you're afraid to move here and there, you're causing more muscle tension, and that muscle tension alone could be, causing some of your muscle pain.
Yeah.
So.
Yeah, absolutely. And I think this one, like we were talking about before, it's just an incredibly common one. And like a lot of these aren't necessarily driven by patients or anything like that. They can be driven by this mantra or aura that the physicians, like you said, have created. A lot of times physicians are making a lot of these recommendations, and it is just on the knowledge and what we know about it and what the research says. So a lot of this can be on physician driven too. So jump into number 8 here. Repeated spinal loading results in wear and tear and tissue damage. I think tying this one kind of back into degeneration and x-rays and things like that. I think as this is what I think, I guess, what people think is that as people move, they just naturally think things are breaking down. Like I walk today, things are just kind of, as I grow old, things just kind of naturally wear down. My joints are, there's degeneration, all those sort of things. So, and we know that's just kind of not the case, in that, putting our spine under different loads and different movements is incredibly healthy for it.
Yeah, and the phrase wear and tear is used a lot with, things like knee osteoarthritis is one of the more common ones. Like, it's bone on bone, and they're rubbing together, and they're wearing and tearing. But we know that the more you move a joint, the more you actually produce fluid in the joint, and that fluid actually creates a pressure that separates bone. So it would be counterintuitive to think that the more you move that you're damaging yourself, when really the more you move, you're keeping things lubricated, you're keeping things hydrated. And especially in the spine too, we have the discs in between each vertebrae. They're like sponges, and the more we compress them, squeeze out fluid, and then we let them decompress and it sucks up fluid, that's how they get their nutrients and their blood supply. So the more we can actually squeeze them and decompress them back and forth, the more healthy they'll be in the long run.
Yeah, absolutely. That's, again, a great point. Next one kind of again tying into pain. Pain flare-ups are a sign of injury and require rest. We've kind of obviously hit on this a little bit, but just because you have pain, whether it's new pain, old pain, something that's a flare-up that you've had before, it doesn't mean that, there's tissue damage or you've gone under an injury or that you require rest or anything like that. And, we've kind of, as we've talked about, how important positive mindset is. And the more fear you have of movement, your recovery time is going to be more slow. So, yeah.
Absolutely. Yeah, it's no different than if I decided tomorrow I'm going to work out for the first time in years. I might wake up the following day sore, and I might consider this that I'm damaged. But really, it's just that I've done a little extra activity that I'm not used to. And sometimes, the brain just likes to protect itself and protect the body. So it might say, yeah, you pushed yourself a little farther than you used to today. So maybe tomorrow we kind of give ourselves some time to, relax. And so the pain isn't necessarily a sign of damage. It's just a sign that we need to fulfill the equilibrium. And for every time that we have high activity, we also need a little bit of rest afterward. But that doesn't mean bed rest. That means active recovery is a better approach. So staying moving, but maybe at a lower intensity.
Yeah, absolutely. Number 10, final one we have here for you guys. This one plays strongly into chiropractic and what we do. Treatments such as strong medications, injections, and surgery are effective and necessary to treat low back pain. This one I feel like almost is, while it is, I still think very commonly thought, I think we're kind of moving to a point where it's less and less thought of. I hope, at least anyways, as research continues to come out. But yeah, the research behind conservative care for a variety of conditions, mainly low back pain, is very strongly considered to be sought out first versus injections and surgery. Affects surgery, all that affects a variety of things in terms of outcomes and your recovery times and mindsets around that. And I know you'll probably, TJ, have a few statistics for us on that.
Yeah, and that's just the nature of low back pain research, is that, as Albert Einstein said, the more I learn, the more I realize how much I don't know. And I think, not just chiropractors, not just physical therapists, but the entire healthcare profession as a whole we came up with all these answers that we thought we knew about back pain. But then now that we're studying it more and more, and we're acquiring more and more data as the years go on, we're realizing how many times we just kind of filled a void in our knowledge with, myths or information that's not accurate. And so, yeah, we've found that, if we have disc degeneration and we go in there, we remove the disc and put in an artificial disc, that it's going to fix pain, and it doesn't. We've found that, maybe if we go and inject the joint with some kind of solution, a steroid or whatever the case may be, or, platelet-rich plasma and stem cells are on the rise. And we don't know what the results show, because we're taking this from an anatomical approach. We're saying there's a piece of anatomy inside you that's causing your pain. And I think that's where we go wrong, is we just have the wrong perspective. We think, you're broken here. If I can fix this broken piece of anatomy, your pain will go away. And that completely discredits the complexity of pain, and the fact that it's only partially anatomical, it's partially psychological, it's partially cognitive, and then social aspects as well play roles. So yeah, to say that anything can go in there and cut you open and fix it and sew you back up and you'll be fine, it's fallible.
Yeah, absolutely. And like we've kind of touched on a little bit here, a lot of these notions and a lot of these that we've mentioned are driven kind of by, physicians and how we've treated patients in the past, and, research at the time, and what we decided at the time was right. And a lot of those things, I think, just stuck, or we haven't, I guess, maybe adapted to education, or, whatever the case may be. But, in a lot of these situations, I think us as physicians, we play an incredibly important role in helping curb some of them, and doing things like this, getting it out to the community, and helping educate our patients specifically on things that we do, and myths around back pain and facts around low back pain, and how the thoughts, everything that we do, play such an important role in all that. So I don't know if you have any final words you want to put out there about any of this, or.
Yeah, I would just say that the importance of this conversation that we're having, and the reason why we chose to talk about back pain is that, even chiropractors, we're spine experts. I would say there's no other healthcare profession that's better at treating back and neck pain, which is the number one cause of disability. But it's not because we have the latest, greatest tools, or, the most innovative ways of treating you with our hands, or that we're better with our hands, or, I really don't believe that at all. I really think it's just the fact that we take the time to sit down with you and properly, educate you on your diagnosis, and we reassure you that you should go back and live an active lifestyle that's meaningful to you. And I think the chair is the most useful tool I have in my room for treatment. It's just sitting down and chatting. And I think, the more that we can set the record straight, and we kind of educate people on what we've learned so far about back pain and what is no longer known to be true, I think that alone will change our perspectives, and that'll influence the way we behave to the next episode of back pain that we're all bound to have at some point.
Yeah. So. Yeah, absolutely. It's, those are all great points. And more of these conversations need to be had with not only us as physicians, with the patients themselves too, to create that great atmosphere. And I liked how you said the chair, it's the most useful tool. It's such an important part. That's why people seek us out. They want to be heard, and sometimes they're not always heard. They feel in the medical community, and that's why we're here. So, I guess we'll wrap that up. I want to thank Dr. Williamson for coming on. That was incredibly resourceful. I can't wait to share this with everyone, and just, get more information out there for, like we said, not only us, for our patients, the physicians, to just better serve our communities. So thanks, Dr. TJ, and we'll catch you soon.
Absolutely. Thank you for having me.
Yep.